am absolutely delighted to be able to introduce our next speaker, our keynote speaker, who is Dr. Alain Gregoire. Alain is the founder and the chair of the Maternal Mental Health Alliance, and for 25 years he has been an NHS consultant specialising in mother and baby psychiatry and setting up a mother and baby unit and a specialist mental health service. He's also a member of the NICE Guideline Development Group and has contributed to the development of policy, guidance and clinical services in the UK and abroad. He's also closely involved in the making of the BBC documentary My Baby, Psychosis and Me, which some of you may have seen. And he's also one of the presenters on the BBC Two award-winning series Trust Me, I'm a Doctor, which again, some of you may have seen, and I hear a new series of it is due out in the next month or two. And that is just a snapshot of all that he is involved in, because he is determined to ensure that all women have access to care for their mental health during pregnancy and the postnatal period. So please welcome to the stage our keynote speaker, Dr. Alain Gregoire.
Thank you very much, and I'm also completely knackered, so whew. But at least it's taken 10 minutes out of my talk, so that's good. It's a huge pleasure to be here. I arrived last night, and you know, in the news across the UK, I come from England, south of England. In the news across the UK, we're hearing that this is a time of potential momentous change in Northern Ireland politics, and that we're reminded of the need for that because of the incalculable human suffering that has arisen from political failure and the deaths that have arisen from political failure, but that this might be about to change in a big way in your politics. And my taxi driver said, we might be getting Stormont, a government back here again. But that's not what I meant. I mean, it's perinatal mental health. At last, after all that suffering and all those deaths, is being taken seriously by your politicians. So really, frankly, them getting together and forming a government in order to push through perinatal mental health care change in Northern Ireland is not a big ask after their terrible failure. So that, you know, if they open Stormont only to push this through, they'll be doing something really, really important. And you know why, because I'm kind of preaching to the converted here. I realise that. And there are more people in Northern Ireland than just you lot. There are people out there who've never heard this message and who aren't aware of the critical importance of what we're talking about, not just to women, a few men here as well, not just to this generation, but to men and women for many, many generations to come. And that is not a wild, manic statement. That is a scientifically based fact. And we need to get it into the heads of the people who are not making the decisions that have been waiting to be made for 25 years at the very least, because that's how long we've had this scientific knowledge in our grasp. We need to get it into their heads so that they take action, and so that they stop talking and start doing. And I know even talking in Northern Ireland is quite a difficult thing to do, and yet you never seem to stop talking, so I don't get why that should be, which seems odd to me. But anyway, I hear that politically that is a challenge. We've got to put a stop to this, and many of you are mums, and you know how to deal with naughty boys. You know, you just tell them to bloody well get on with it, because there's important stuff to be done. So, in that spirit, I kind of see you all as not just the converted, but actually the converters. You are the ambassadors for this cause, and you have an enormous job to do. And the job will not be done, even if all that we wish for today gets put in place, because there will still be a lot more to be done in order to get it right, and in order to answer the challenges that the science is putting before us. So this is a fantastic opportunity this time. We are so lucky to live in this time. And I'll share with you a little bit of that very, very compelling evidence that gives us this opportunity. But we need to do stuff with it. It's not good enough to just sit on our backsides and feel good that this is wonderful and this can be done. It's got to be done. Earliness is kind of trendy, particularly in mental health, because we've got this notion that if you intervene early, if you get in there early, you can get better results quicker and reduce suffering and death. And that's undoubtedly true. But we need to remember in perinatal mental health that we're talking early in terms of days, weeks, months, years, decades, and centuries. So if we act now, we can make a difference in the next 30 minutes, but we can also make a difference in 100 years' time. And that is really unbelievably unique in healthcare. And frankly, to anybody in public healthcare, it's a dream come true. So why wouldn't we get on with it? And it's more than that. It's all the other things that are trendy PC speak in healthcare, actually for very good reasons, so I'm not making a denigratory comment there. In perinatal mental health, you have to integrate community and inpatient care. And I've heard a bit about, do we want perinatal community services or do we want mother and baby units? You want everything, and actually far beyond the specialist. Women, children, families, this generation, the next generation, deserve everything, should have a right to everything. And it is not good enough to say, well, we can only afford our priorities. There is plenty of money out there. Do not kid yourselves. If this was postpartum hemorrhage, somewhere the money would be found, because blood on the floor counts. And you wouldn't be waiting political decisions or Stormont rooms to be filled with people again in order to deal with blood on the floor or casualty departments not functioning. But we tolerate and accept mental health services not functioning, as you heard this morning from these sofas, leading to appalling suffering that is frankly an outrage and an embarrassment. So community and inpatient, you absolutely must have an integration of specialist services with primary care, of physical health care with mental health care, of acute emergency care. And this is the closest you ever get to the concept of an emergency in psychiatry, is perinatal mental health problems, particularly psychosis. So you need acute care and you need chronic care. Integrated. You need professional care with peer support, integrated at every level. And peer support isn't just for the so-called mild to moderate or the so-called worried well. And within those concepts, I should add, are a huge amount of human suffering that in physical health care would immediately lead to attention. But because it's mental health care, we kind of push it away because we think it's a bottomless pit. So we'll only deal with the horrendous and the noisy and the disruptive. So you need that, combine that peer support at every level combined with professional care. You need medical models and psychosocial. It's no good saying, oh no, I'm in the medical camp, I don't deal with that, or I'm in the psychological, or I'm in the social. We all must function in all of those, or we cannot deliver good care. And we cannot take ourselves seriously in the field of perinatal mental health. And we are in the UK, even in Northern Ireland, where you think you're behind, when you look globally, we are ahead of the whole world. And I will tell you at the end how the whole world is watching you in Northern Ireland, how you deliver services to your women and your children. So here we are, again, preaching to the converted, but what I'm trying to do here is just maybe give you some system for classifying the overwhelming amount of information that we need to convey to people, to the other people outside this room, and to the decision makers. So the question is really, why perinatal mental health? Why is this a priority? Why is this at least as important as casualty departments? Because we have clear evidence. We know exactly how much suffering is out there. We don't appreciate it. We don't truly feel it and understand it until it's brought to us face to face, either in our clinical practice or from people crying through the experience of sharing it with us and suffering in front of us because they think it's so important that we hear it. But we know that both in terms of quantity and quality, statistics and personal experience. We have very good evidence of the economic need and the societal need. So we know the impact of this on our society. We can easily calculate the number of people who are affected and the number of people who are critical to our social function of our society who are affected by this. We don't know as much as we could do. We don't know exactly, for example, how many days are lost from work by grandparents and by partners. So we don't have that sort of data. But you can guess, and those of you who work clinically are very familiar with the impact that these conditions have on the wider family. We have clear evidence of not the spending that's needed, but the investment that is needed, because there will be returns. And there will be some pretty quick returns that in physical health care we wouldn't doubt for a second. You know, if somebody is bleeding all over the floor, you don't go, well, is it cost effective? Actually, if they died, we'd save money. And mopping up the blood, how much does that cost? Well, 3 mops and the cleaning lady, and maybe it's best not to stop the bleeding. We have to do that in mental health. We have to make these calculations. Quite why, I don't fully understand, because I don't know what government is for if it's not for the people and for the well-being of the people. And as Lincoln said, of course, for the people, what did he say? For the people, by the people, that government should be run, and it's for the well-being of people. So should we really be questioning that? Well, we have to. But we have that evidence, in fact. We know that investing in mental health at this critical time pays huge economic dividends. We have clear scientific guidance of the interventions that work. And there's lots that's done in health services and indeed in social services that is not in any way evidence-based. But we do it because we just have to do it. You can't not do it. Well, with mental health, it seems acceptable to not do stuff and just to leave people languishing, even if we have the evidence of what we could do. And that applies across the whole world. It applies across the UK, and I may be able to tell you in a moment some good news stories from other parts of the UK, but we are still a very long way from doing everything to help and support mums, babies, and families that we could do according to the evidence. And we were hearing earlier on about, are we nice concordant? We have to honestly say no. Well, we can honestly say there is nowhere in the UK that is yet nice concordant on perinatal mental health care, even with the developments that have happened so far. So we've got a way to go, but we absolutely must do it, and I can show to you that we absolutely can do it, and it is possible to do it all. So we have successful models for how to deliver that care. We have quality standards and assurance systems. They exist, they're there. And quality enhancement systems, they're there. And we heard earlier on how actually all of what you need to do has been done and tested before. So yes, by all means, agree what needs to be done in Northern Ireland, but don't spend too long about it, because women, babies, families in Northern Ireland are not genetically different to all the other places where these models have been tested. Just get on and bloody well do it. And then finally, and that's what the Maternal Mental Health Alliance is about, demonstrating that we have the active support and the consistent support for doing all of this. So everybody agrees. Now surely that is a politician's dream, a clinician's dream, and everybody who comes in between those for just getting on and doing it and delivering. There is no disagreement. Everybody agrees, all the policies agree on what needs to be done. And yet we still don't do it? What possible excuse can there be? Okay, let me just move on a little bit to thinking about the condition. So what is it that we're talking about? And I appreciate that you're all very familiar with these things, because that's kind of why you're here. But let me start with just getting you thinking a little bit about the flip side to perinatal mental health problems. And here's one of the flip sides. What is normal in terms of thinking as a mum, and indeed as a dad, about your baby? So just talk to the person sitting next to you. I'm going to give you about 1 minute, okay? What are the percentage answers to these questions? Go. You haven't got much time.
Would you mind saying that we're happy to take questions?
Oh, okay.
You're happy to take them. Thank you.
Okay. You've had your minute. So somebody shout out, how common are thoughts of accidentally harming your baby? 80%. 80%. Any increase on 80%? I have 80% down here. I've had 80%. 90%. I have 90% over here. Any increase on 100%? Yes, 100%. It's completely 100% normal to think, oh, I'm just going through this doorway and I might hit my baby's head on the side of the door as I'm going through. I don't want to, but it might happen. It's normal, it's normal. Oh, God, this tiny little baby, what if it slipped through my arms and I dropped it? Yeah, and then social services be down on me, and what will I invent as an excuse for dropping my own baby? Oh my God. Thoughts of deliberately harming your baby. Percentage? Sorry? 70? I had 5? 10? 70? 10? 30? 80? Okay, yeah, you're closer to the ballpark. So about 1 in 2 women say they have had thoughts of deliberately harming their baby. Not wishes, okay, but thoughts. Oh my God, if I get to the end of my tether again tonight, I might throw him across the room. I don't think I can be in the same room with my baby. You know, I'll have to get my mother to look. Tonight, I just can't cope any longer. And I might do that, and that's a horrific thought. And I better not tell anybody, because if I tell my health visitor I've had that thought, she'll know straight away that I'm the useless mother that I am. Yeah? And actually, if your health visitor thinks the rate of that thought happening is 5%, she might well think so. Yeah? But if she realizes that at least every other parent gets that thought, she might be a little kinder in her analysis of what's going on. Frequent thoughts, every hour of that nature. How common is that? 5%. Yeah, probably around 2%. So much rarer. Constantly happening. Yeah? And we call that obsessive compulsive disorder, because obsessions are frequent thoughts that don't really make logical sense, that could be very frightening, that you don't want to have, but you can't stop them coming in repeatedly. And that is really a horrific, anxiety-provoking, because if you get that thought that often, you think, well, there must be truth in it. If I get it that much, surely it must be true. Because other people don't get that, and they're sort of right that not many people get that much. Does it mean it's true? Do any of those mean that you are going to hit your baby on the side of the door, or that you are going to throw your baby across the room? Do the thoughts mean that you will do it? Fantastic answer. What is the risk, percentage-wise? Less than 1? Why'd you say less? What's less than 1? Because you just dare not say there is no risk, because you want to protect yourself a bit. So you leave the woman with, oh, well, it's very, very low. And she thinks, well, then I'm the one, doesn't she? So you're protecting yourselves with that less than one. The risk is nil, zero, from those thoughts. Now, there may be risks from other things, like the thought that I want to throw my baby out the window because the world is such an awful place, or because the devil is coming to get us. But that's not these thoughts, okay? Yeah? Does that make sense? And your role is critically important. And your role in going out and telling your colleagues about this is critically important. Because women need your confidence, not your defensiveness, if you're genuinely going to help them. So there you are. So understanding that difference between normal and abnormal, and what is normal as well as what is abnormal, is part of mental health care, just as it is part of physical health care. I've got this terrible pain here. I think I must have appendicitis. Well, let's have a look and just see. No, we really don't think it is, but if it carries on, come back and see me. Yeah, this doesn't look like that. Or maybe this looks like a urine infection. Let's have a look. Oh, yeah, it is a urine infection. Confidence, I can deal with that. I can help you with this. I can take away your anxieties. It should be the same with mental health problems and the boundaries between normal and not normal. So what about not normal? Well, you've heard this already today, maybe not represented in a graph, but depressive illness is the most common major health complication of having a baby. There is no other health complication of having a baby that is as common as depression. Now, some of you might say to me, but that doesn't belong in that list. There's serious stuff there. You know, there's stuff that makes people ill, that makes people suffer. There's blood. Some people even die from some of those conditions. You can't put depression with those. Would they be right? Well, of course you would say that, but you will meet people who say depression does not belong in that list. And they are statistically and scientifically wrong, okay? Because depression kills people, and there is no other condition known to man that causes as much burden of disease as depressive illness, worldwide, even in developing countries, okay? It is the most burdensome disease known to man. And this is the WHO chart for developing countries, for low and middle income countries, from the WHO survey that's done every 10 years that looks at all conditions. But you can see even in high income countries, it is way and above other conditions. Okay. So that's kind of, you know, that's the non-psychotic. And when I talk to my colleagues in mental health, they go, yeah, but that's all very well. But we deal with serious conditions, serious stuff, you know, dramatic stuff that needs to go to hospital. You people in perinatal, you're just, you know, holding nice babies and cooing. There is no other time in human existence when you are as at high risk of becoming psychotic as the first few days postpartum. And it only happens in women. Because, and that's not a non-PC statement, because it happens immediately after birth. There's no other time in your lives, or in the lives of men, when the risk is so high. And not only that, but if you match women being admitted to hospital with postpartum psychoses, with other women being admitted to hospital with psychosis, but not postpartum, the postpartum women are much more ill, their onset is much more rapid, and they are much higher risk. So this is not only the most frequent time for becoming psychotic, these are also the most severe psychotic illnesses you see in the whole of psychiatry. And yet, my colleagues used to, actually it's stopped happening now, but they used to say to me, we deal with serious stuff. This is trivial, and we really haven't got time or money for it. And you here will still get that a bit, because as you start developing specialist perinatal services, you will get the people from general adult services who resent, A, losing the most exciting job they do in the whole of mental health care, which is perinatal, obviously. It's the best job in the world, so I can understand that, but tough, because they're not doing it properly, and that's not an insult, it's a highly specialist area. When I was a medical student, we used to get surgeons in the same operating list doing bowel resections and mastectomies for breast cancer, okay? The same operating list. I know that's difficult to believe, and yes, I am quite old, but that is now completely unacceptable. Any hospital that allowed that to happen, even in an emergency situation, would be shut down, or have the chief executive sacked and the surgeon would be suspended. Because, why? Because we know that the outcome and the quality of care is far inferior in areas that are highly specialized, that are not delivered by highly specialized staff and services. Yeah? And psychiatry, mental health care, has at last come of age and said there are certain areas that need specialist care, not specialist organization rearranging the deck chairs on the Titanic, having home treatment and not home treatment and acute and not acute and chronic. That's all bullshit, okay? That's invented by administrators, I'm afraid, okay? But perinatal is fundamentally and definably different. And we are there, and we're there to stay. So if we delay, all you're doing is increasing suffering. You will not put off the inevitable. Okay, so just get on with it. Who are these women? Well, they are, postpartum psychoses are largely bipolar, either first episodes, and there is no other time in humans when the risk of bipolar episodes are as high as immediately postpartum. So it's the most important trigger we know of for bipolar, so not surprisingly, quite a lot of first episodes, but also relapses. And this study demonstrates very clearly how the red line suddenly changes from the blue line. These are pregnant and non-pregnant women who are not taking medication for their bipolar. When they have a baby, that yellow vertical line, suddenly the women who have a baby show a very different pattern, huge rates of relapse immediately postnatally. But perinatal isn't just about maternal illness. At last, in the research in the last 20 years and in the conversations in services, we've heard the voice of the baby loud and clear. And the sort of research of which there is a huge amount now, all saying the same thing, so I'll just give you a couple of examples from studies done in the UK, but worldwide you see the same thing coming out of all the studies that have been done, both small studies and enormous studies. What you see is that mental health in mothers has an impact. Statistically, okay, not invariably, not in every case, but increases risk. And that clinically, and to you in the audience, of whom many are mothers, and many are mothers who've had anxiety or depression, because it's inevitable that many of you will have had, the message is really importantly that yes, this does increase risk of problems for the children, but it does not make them inevitable, and most children are fine. Yeah? Does that make sense? Do you get that? Yeah? And this is a really important message. And although it is a very important period, this is not an irreversible risk, okay? So you can smoke for 10 years, and 10 years later, if you stop and don't go into some other appalling lifestyle problem, you can get rid of the risk associated with it, yeah? And just the same, good attachment, for example, many of these risks disappear. So some of the risks that increase during pregnancy with anxiety and depression, if you have a good attachment relationship postnatally, then the risk to the child goes back to normal, for example. But statistically across populations, these are nevertheless long-term risks, because many of these children who are put at risk antenatally don't have good attachment relationships and don't later have remedied and repaired attachment relationships and so on. It should also be added that there is no such thing as risk-free parenting. And those of us who are parents know that very well. You know, there's one thing you can guarantee as a parent, which is you'll get it wrong. Yeah, absolutely. Guarantee you'll get it wrong. Of course, the other thing you can guarantee is when they're teenagers, they'll tell you all the things you got wrong. You know, so you know, you can not want them to be bullied at school and not want them to run the risk of being hit by a bus on the way to school, and you lock them in their room for the first 16 years of their life. But you then know that actually that probably isn't a very good idea either. Yeah? So you have to take a balance of risk in almost every decision you make as a parent. And we need to understand that and help other people to understand that as well. You do the best you can. And my God, the guilt you then feel when they're 30 and they don't quite get the job they wanted. Oh my God, it was all my fault when they were 3 years old. I didn't give her enough confidence. Yeah, you know, I'm going through that. Okay. And she tells me. Okay, here's another one. So just a couple of examples of impact on the children. So this is a prospective longitudinal study done in South London, which looked at both the fetuses and the developing children with interviews and observation studies of both the mother and the child. And they looked at their data when the children were 16. And they looked at their data on the mothers and found that every single child who was depressed at 16 in this study had a mother who'd been depressed. Every single one, 100%. Most of those, amazingly, was maternal depression in pregnancy. Yeah? Now, it's not the same as saying every mother who was depressed had a child who was depressed at 16. It's not that way round, okay? But it is the other way round. Does that make sense? Really, really important. So the message is not to women who are depressed in pregnancy, your child will be depressed at 16. Not at all. But it is associated. Yeah? Okay, I'd just like to take a little aside to just talk about how do we predict who are the women who suffer from these mental health problems at actually every level of mental health problem. And it used to be thought, in a very extraordinarily simple-minded way, that the best predictor of future mental health problems is past mental health problems. So in other words, if you've got diabetes, then you're likely to have diabetes. Well, that's sophisticated, isn't it? You know? If you've had depression, then you're likely to get depression. Oh, wow, big news. Well, yeah, okay, to be fair, most of these conditions in mental health are recurrent conditions, so having had one is a very good clue that you might well dip into one again. So I'm being a little bit unfair, but it's not very revealing, is it, about where this all comes from. But there is one factor, actually across the whole of physical as well as mental health, that is the universal predictor of poor human health. And that is childhood. Trauma is one word that's commonly used, but emotional adversity, essentially, is the best predictor we have of how long we live, of the conditions we suffer from, the conditions we die from, and absolutely how healthy our mind as well as our body is. And perinatal mental health problems are no exception. In fact, they're probably, I would say clinically, and I don't have an evidence base because it's been incredibly poorly researched, but from my clinical experience, it's one of the most sensitive periods for childhood emotional adversities to rear their ugly head in a really nasty way for women. And my God, have you got a lot of adults who've had childhood emotional adversities in Northern Ireland for a variety of reasons. And so we owe it to them to pay attention to this. So it is the strongest predictor of perinatal depression, far stronger than a past history of depression. And yet, do we ask about it routinely? Do we ask what was in booking clinics? Do we ask what was your experience of being a child? How was your parenting when you were a baby? And do you think people don't know? Oh, I've no idea. I don't know. I don't know what my household was like when I was a baby. Do you think people don't know? They do know. Do you think they don't want to be asked? Actually, we have good evidence that they do want to be asked. So why don't we ask? Well, A, we don't realize it's important. Why don't we realize it's important? Because there's no evidence? No. There's been evidence for 30 years. And most of you will have heard of ACEs, adverse childhood experiences, yeah? And actually, the question about is therapy, is care trauma-informed, said it all. You do know, but we're not doing anything with that knowing. And we need to start doing something. And if you guys wait, you guys are interested in this field, wait until somebody comes up with the policy, you're going to be waiting until after you've retired. Because nobody's going to come up with the policy that quickly on asking this. It should just be part of good holistic care. And just to cut a very long research story short, we have clear evidence that mothers' childhood experiences, adverse emotional experiences in the mother's childhood, has a direct impact. It works partly through the mother's mental health, but there's a direct effect on their children. So if you are a mother who's had particularly severe childhood adverse experiences, there is an increased risk of your child having difficulties at school, including ones that will be visible and measurable by their teachers. And that's a lot of people, because what's the rate? What percentage of you guys have had adverse childhood experiences? You adult women. Come on, percentage. I'm not asking you to put up your hands. 25, yeah, about 20% in surveys of populations in community studies. And that probably has got to be higher, because there will be people, even in confidential anonymous studies, who can't bring themselves to talk about it. Yeah. So it'll be somebody sitting next to you will have had an adverse childhood experience. And we don't, not generally talking about single experiences, we're talking about protracted problems. Yeah? Now, the interaction between adverse childhood experiences and poor mental health in the perinatal period is profoundly important. And this is where we get this story of a transgenerational effect. If you add together both the direct effect of adverse childhood experiences, but you add that to the indirect effect of those experiences working through poor mental health, that's where you get the double whammy. And that's where you get the really higher rates of difficulties in children. Still, most of those children will be okay, still not irreversible or inevitable, but a substantially increased rate. Yeah? And that is why this is so critically important, because this is multi-generational. And for the first time ever, we have the knowledge and the power to stop it. No generations have ever had this knowledge before. This is so exciting. This is not depressing. This is fantastic news. We can change this for our children and our children's children. Why wouldn't we do it? And I'd just like to divert on the slightly psychiatric topic of what we call this. So this is what happens if you suffer trauma, either as an adult or as a child. And it's pretty understandable. You don't need to be a clever psychoanalyst or a, deeply steeped in psychological training to understand why you would be wary of other people, yeah? Because these traumas that have an impact, these ACEs, are largely interpersonal traumas. They're to do with the people you interact with as a child and what they do to you or don't do to you. You wouldn't trust anybody. Any little thing, like the way somebody looks at you, or a red front door, or somebody wearing a belt, could bring back traumas that would be completely invisible. Those cues could be completely invisible to other people. But somebody might go completely in a terrible emotional state when they see them, and you just think, well, what are they doing? 1 minute they're fine, next minute they're all over the place, and then they settle down again. Or just one word that you use in your conversation with them, and they shut down, they stop listening, and they go in some other world. Yeah? They blame themselves, because of course that's what children do. How do we learn? Well, we do something in the environment and we watch what happens. That's how children learn. Yeah? You interact with the environment from birth, from before birth actually, and you watch what happens. Well, if terrible things happen, it must be something you've done. Yeah? So it's very understandable. And then, of course, if you can't escape physically from this repeated trauma, like it's bullying at school and you get sent there all the time, or it's bullying in your home, or it's physical or sexual abuse that you can't get away from, what do? Well, you mentally get away. You shut down, you stop listening, you stop being aware of your surroundings. And you take that with you as a mechanism for getting out of challenging situations. Or you go into a fantasy world, yeah? Does that sound familiar? Does that description of people? You've seen people, those of you who are clinicians, those of you who have lived and interacted with other human beings? Do you recognize that list? Don't you? I see them all the time. Don't you? Yeah? So who are they? What do we call them? What do psychiatrists call them? Yeah? When it's really bad and it gets as far as a psychiatrist because it's so dysfunctional, this pattern, we call it borderline or emotionally unstable personality disorder. Phew, that's a relief. Back to you lot, yeah? Because we can't do anything to treat that. But this is changing. You are on the cusp of a dramatic change. Because as you'll also see, any of you who work with PTSD, and many of you do, it's almost the same set of patterns of thinking and behavior as PTSD. Yeah? And we're now beginning to understand that this is a form of PTSD caused by trauma in childhood. And by trauma in childhood, remember, I'm not talking about a traumatic event, I'm talking about emotional adversity. And for babies, what is that? What's life-threatening for babies? Can babies be traumatized? Is that possible? By what? Being ignored, yeah. What allows a baby to survive? What's life-threatening for a baby? Well, if you cry for food and nothing happens. If you cry for brain development and nothing happens. Like that baby that was already switched off at 3 months that you saw in that video. That's trauma for a baby. But we keep thinking, when we think trauma for adults, being shot at, being slapped, being raped. That's not what trauma is for babies. And we who are interested in perinatal, must have that sophisticated understanding of what is traumatic for a baby and not go along with this commonly held public belief that if you can't remember it, it can't possibly have traumatized you. Because science, we know, you know, tells us something completely different. That actually the earlier it happens, the more likely it is to have a long-term effect on your life. Yeah? And you need to know that because other people don't get it. Please, if there's any message you take with you from what I've said, please take that one with you. And we do harm. We re-traumatize people by A, not acknowledging it, but secondly, certainly we psychiatrists, my colleagues and I say it with shame historically, that I used to, in the nicest possible way, explain to people that their personalities were disordered because that was what I was trained to do. And it's bullshit. It's not their personalities. It's that they have a very normal reaction to a common but life-threatening abnormal experience very early on in their childhood. And the vast majority actually know it themselves. But the number, since I changed my practice 10 years ago and at last came to an understanding, to my shame, they say to me, well, I've always known that, but nobody's ever acknowledged it to me. And in perinatal, this blows up bigger than, in my view, any other time, but certainly any other thing we see, possibly apart from postpartum psychosis. Can we do anything apart from just being understanding and genuinely understanding what's going on and explaining and empowering? Well, we can. There's loads of evidence of effective psychological interventions for so-called personality disorder, because that's where you have to go looking in the literature. Because ICD-11 has just come out with complex PTSD, and there is almost no research on it in that form, in that name. But if you look at personality disorder research, there's loads of good models for interventions. It's just these are really difficult people to help because they switch off when you try and deal with difficult stuff with them. And we don't like that. We like people who appreciate us and are nice to us and make us a nice cup of tea and like us to come and are not inconsistent and don't say, fuck off if you're going to be like that with me all the time. Whereas all you said was, how's your dad? You know. Yeah? You know them, don't you? Well, you don't go back there, do you? And that's why they build this wall around themselves so as not to let people near. That's why the only people who get close to them are those who don't give a shit about their wall. The controlling, bullying, violent types. That's why they end up in those relationships. Because the nice people go, oh, sorry, I'll stay clear of you. And so that's why they get socially... It's obvious. I mean, it's completely obvious. Nothing clever about this. But we just don't like it. So we stay away and we don't really want to understand. But we can do stuff. So this is the first example I know of perinatal emotional coping skills, so based on DBT, intervention for a perinatal population. Oh God, I'm going over time. Shit. I was going to say that, well, I'm going to leave time for questions. Please do put some questions out. And I suddenly look at my watch. Okay, I'll speed on. Okay, so we can do stuff. You just need to do it. And this has to be done within perinatal interventions. It has to be done in a way that's consistent with being a parent. And it is a fantastic moment to do it. Because this is a moment when people with these conditions are prepared to go the extra mile, to confront some of their suffering, to try and deal with it, because they want things to be better for their children. So if we don't grasp this opportunity, it may disappear again. And that's happening now as we sit here. And we did a survey of the women we were seeing in our specialized services, and in the MBU admissions, 50 to 80% of them, and the higher figure came from a colleague of mine who did the same thing at the Bethlehem Mother and Baby Unit in London, an R rate, just casually asking. So we weren't doing in-depth, persistent interviews with them, but 50% of women were talking about their childhood traumas. And in community perinatal patients, just surveying the referral letters that we were getting. The referral letters contained information about childhood trauma experiences in over 50% of our referrals. So this is incredibly important in perinatal work and an incredibly important opportunity. What do we know about what we do generally? So we can do stuff with that group. Of course we know we can treat depression, we can treat anxiety, we can treat psychosis, but are we good at identifying the women who need help? Well, we aren't. And that's not because we don't care. It's sort of at a level because that it's more convenient to just ignore this unpleasant, difficult fact because we're all incredibly busy in the way that we wouldn't ignore blood on the floor even if we were incredibly busy. But it's also because it's difficult. It isn't easy identifying depressive illness or complex PTSD or anxiety disorders. And people have very good reasons, as you heard from the NCT work, for keeping this information to themselves. We are partly responsible for that. We can't dump that on women and say, oh, well, you don't want to talk about it. It's something about the way we deliver care that's at least partly responsible for people not wanting to talk about these things, and the way we cover ourselves, and so on. And this, that I just, mentioned in this slide, this fear of talking about thoughts that we were talking about at the beginning, and fear that your child's going to be removed. But at the same time, that's mixed with a knowledge that's probably realistic, that most women say they have, that this has an impact on other people. Yes, it does. But they're fearful of talking about it because they fear the damage that might be done by our response. So somehow we've got to think of a way of taking away that fear. And of course, we're not doing very well from the death's point of view, as we heard earlier. You know, if this was death from a physical cause, quite rightly it would be dealt with, but because it's from a mental health cause, it's not being dealt with. And our investment in physical health care in maternity has been fantastic over the last 50, 60, 70 years of the NHS and has brought down deaths from physical causes dramatically. okay? We can do the same for mental health, but we haven't. And it's about time we started. And we didn't hesitate to do it for physical health, so let's get on with it for mental health. And the lessons are always the same. You could write them on the back of an envelope with anything that goes wrong in healthcare. It's always the same lessons. You don't identify the high-risk group. You don't understand that it is a high risk if you do identify it. If you understand it's a risk and you do identify it, you don't tell anybody about it. And if you do tell people about it, nothing actually happens, nothing gets done. And that combination is when things go wrong. Most of the time, somewhere along the line, something goes right. And most of the time, women don't die. But when things go wrong, that's why. And it's always the same reason. So you don't really need to do a confidential inquiry. We know. We just need to get on and do it. But the confidential inquiries keep feeding us until eventually we go, oh, all right, let's do something about it. And if all of that doesn't interest you because it's all clinical and about humans and all you care about is numbers, and yeah, you know, we do have these people in our society, some of them work in the Treasury and places like that, then let it be said loud and clear that leaving things as they are now in the UK, so this is not doing nothing, this is just carrying on as we are, is costing us, at a very conservative estimate, so only costing up 3 conditions, and only a 10-year impact on children, whereas we know there's at least, from the science, a 25-year impact. It costs us 8.1 billion per year of women giving birth. And to do everything that NICE says is the green figure, written in proportionate font. Okay? So don't let anybody ever tell you that this is an expensive thing to do or we can't afford it. Don't let them. It's outrageous. It's a con to say that. It's just hiding inaction and inactivity. All right? If I offered the politicians a fantastic healthcare system that would just cost £8.1 billion, right, and would deliver bad care and death, would you go for it? Go on, go on. Just give me 8.1 billion, and I'll give you poor health care and poor outcomes for this generation and the next. Go on. Well, that's what we're doing. What's the point in that? And this is such a great opportunity. There is no other time when we can detect depression in women so quickly and so commonly, and when there are already services in place. Every policy is in agreement. We've got models. You've seen all of this stuff before, so I'm going to race through it also because I've run out of time. But you've seen these models before, and we've got answers for every bit of this model. We know what needs doing right across it. We're actually hardly delivering on any of it. We know the pathways. You can write them on the back of an envelope. Yes, you can have a committee for 2 years designing them, and then you discover that nobody follows them. But actually, if you've got the services on the ground that are committed, having the pathway can be helpful, but it's the conversations and the care that's delivered that keep these pathways alive. It's not the document and the piece of paper. So it's worth doing, it's worth talking about these pathways, it's worth getting all these various organizations together across the table, but it's not the document that does it, it's the getting together and then followed immediately by the funding and the delivery of care. So what do we want to see happen? Well, here you have it. Here's a short list of what you can do now. And frankly, why you don't do it is exclusively because somewhere somebody is just not bothering to make the decision. You can have pathways, and you have already got them on paper across all services. You haven't got them in action, but you can hardly expect that if you don't have the funding for people to deliver pathways. You haven't got the specialist community teams. You need to have them. You can't have the pathway without them, so get on and do them. The models are there. They're well established. There's no excuse. Just do it. Access to therapy, we know what the therapies are. I was talking at lunch break to some fantastic psychologists. You've got the therapists, they're desperate to do the work. Just bloody well pay them to look after your mothers and your babies in Northern Ireland. Peer support, you've got fantastic setups for peer support. Just get on and do it. You know what needs to be done. Mental health care and maternity and health visiting, you're crying out to do it. Just give you some time. Nobody would say, don't look after diabetes anymore. Nobody would say, don't check whether the baby's growing. Well, they shouldn't be saying, don't look after mental health. They shouldn't be saying it. And effectively, passively, that's what you're being told. It's not on, it's not acceptable. And we need specialists. We need specialists at every level. We need specialists in maternity services, specialists, dedicated midwives with time to train others, to supervise others, to advise others, and maybe do a bit of direct care themselves. And the same amongst health visitors. It's cheap. Okay, I've said it's cheap before. Here's another way of cutting it. Physical health care in maternity, just maternity services, not the primary care end of it, costs £2,800 per birth. Okay? Negligence costs per birth, 690 quid per birth. Specialist perinatal mental health care, that which is too expensive, that which we need to debate endlessly before we could dare to take any action. 83 quid. 83 quid. How dare anybody say it's too expensive? How dare they? The whole pathway, including more time for midwives, including more time for health visitors, including specialists, 407 quid per birth. Do not ever let anybody get away with saying there's no money. Okay, because we're spending it now on bad care. And why start with specialists? Well, oh God, am I allowed to? What am I going to do? What am I going to do? It's so exciting. Okay, look, I'm sure you can have the slides. So I'll just run through that. It's obvious why you need to start with that. You've heard it several times today. What they do, well, we know what they do. If you're interested, go on the Maternal Mental Health Alliance website, go to the resources pages, and you'll see loads of documents all saying exactly the same thing about the model of care for specialist services, okay? There is no need for debate, okay? The models of care work. They're fantastic to work in. They deliver fabulous services. What's not to like? Just do it. Okay, yeah, and you know, if you want to tailor it, don't waste time. Just get together one afternoon and say, okay, well, down here we'll have one less CPN and one more OT, or we'll have a bit less psychiatrist and a bit more nursery nurse, but just fucking get on with it. And if you put your mind to it, you can do it. Okay, this is the UK, all right? Green is fully functioning perinatal mental health community specialist teams, okay? So I've been mapping this since 2004 in my spare time, as my wife calls it, yeah. And these are when I've done the maps. And you can see the dramatic change that happened when England decided, when actually the Prime Minister said, here's the money. Okay, and then suddenly, boom, it just happened. Okay? And all of that growth in green is an England growth. As you know, it's certainly not a Northern Ireland growth. And I'm afraid it's not a Wales or Scotland growth, but that's coming. That's just in the pipeline now. So you've got, catch up. And you're so small, you know? You could do it now. You could be there before Scotland, before Wales, before England. Just do it. So this is the map in 2015. I won't show you the earlier maps. They weren't so pretty, but you know, that shows pretty clearly. Red is nothing. You know, women can't even get advice from people who know what they're talking about. Imagine that in cardiology. You know, I've had a heart attack. There's nobody within 100 miles who knows anything about heart attacks. Outrageous. And this is 2 years later. Look at the green. You know, it's like spring. And just to reassure people who pay for it, you know, we know how to assure quality. We've got all the measures, we've got the systems, we can do it. In fact, one of the best quality assurance systems in the world of healthcare is in perinatal mental health. We've got routine data outcome tools, so we can measure outcomes in perinatal mental health specifically. We've got beautiful models of care, and it's possible to grow them. So in a year, we built 4 new mother and baby units. In a year. Okay? They're open. You could do it. It's not rocket science. And we know, incidentally, that mother and baby units and community services are better for mothers. So this is a measure taken at the Bethlehem Mother and Baby Unit across all diagnoses, and better for babies. So don't let people say, oh, these women are too ill, they shouldn't have their babies anyway. The outcomes are better for babies, in some cases better than normal community samples in mother and baby interaction when they leave mother and baby units. And we know how to map the whole pathway, so go to our website if you're interested in that. And I repeat, we can do this together. And worldwide, we now have a global alliance for maternal mental health that is trying to change the whole world. And I can assure you, I'm now doing quite a lot of traveling with this work, the world is watching the UK. And one of the things they say to me is that part of the UK? That red bit up there? It's on a different island, but what's going on up there? And I say, well, nothing. But actually, that's unfair, because you're going on up here, okay? And you're the ones, sorry, it's a bit of an English, You're the ones who can make this happen. You are the ambassadors. So don't kid yourselves that you're just clinicians struggling, okay? You are revolutionaries that are going to change the world, and on your gravestone is going to be written, I improved the lives of many generations. What more could you ask for in your professional or private lives? I'll shut up at last. Sorry.